Hey everyone, welcome to the Deep Dive. Today we're tackling congestive heart failure. You know, it's a topic that often comes up when prepping for the MCCQE.
Definitely a big one. And as MCCQE reviewers, we want to make this as painless as possible for you guys.
Absolutely. Think of this as your crash course on CHF.
We'll break down the toughest concepts using reliable sources like, those Stat Pearls articles.
Oh, and before we dive in, remember, this is for informational purposes only. It's not medical advice. Always consult with a qualified healthcare professional.
Always good to get that out of the way. So, CHF. It sounds scary, but how would you explain it simply?
Well, it's basically when your heart, for whatever reason, can't pump blood as well as it should.
Leading to all sorts of issues, right? Because the body isn't getting what it needs.
Exactly. And the symptoms, those can be all over the place, depending on the severity and the cause. But before we get to that, we should talk about the different types of CHF.
You mean HFrEF and HFpEF? Those always seem to trip people up.
For sure. But they're pretty straightforward. So HFrDF, that's heart failure with reduced ejection fraction, meaning the amount of blood the left ventricle pumps out each beat is low.
So the heart's not squeezing hard enough?
Right, like a pump losing power. Now, HFpEF, that's heart failure with preserved ejection fraction. That one's trickier.
Because the ejection fraction might look fine.
Yeah, but the heart muscle, it can't relax or fill right between beats.
Huh. Like trying to fill a stiff container. Even if you pour the same amount, it won't hold it all.
Great analogy. And this is where it gets interesting because HFpEF, it's often tougher to diagnose. Symptoms might be subtle, easily mistaken for something else.
And it wasn't always as well known as HFrEF, right? Even though it's a huge chunk of cases.
Absolutely. Okay, so two main types. But the causes, man, they could be so varied.
Yeah, pinpointing the cause is like a puzzle. And it makes a huge difference for treatment. So what causes CHF? We all know heart attacks are bad, but what else?
Well, ischemic heart disease is a biggie, often caused by coronary artery disease. And it's not just heart attacks. Even chronic low blood flow to the heart can weaken it over time.
Right. And then you have those valve problems like stenosis or regurgitation, messing up the blood flow, and, rheumatic heart disease. Still a problem in some parts of the world, damaging those valves.
Good point. Reminds us that CHF causes can be different depending on where you are, geographically and stuff. What about things that aren't directly related to the heart? Can they contribute?
Definitely. High blood pressure, if it's not controlled, puts huge strain on the heart, leading to what we call hypertensive heart failure.
So even without a heart attack or obvious heart problem, chronic hypertension can be a setup for CHF.
Exactly. Then there are cardiomyopathies. These affect the heart muscle itself. Some are genetic, others come from infections, toxins, even medications.
Yeah, lots of myocarditis post-pandemic. Got to ask about that during history taking.
Like solving a medical mystery, sometimes the clues are in the patient's past.
So we've got ischemic heart disease, valve issues, hypertension, cardiomyopathies. Anything else?
Well, there are some less common but important causes. Infiltrative diseases, things like amyloidosis, sarcoidosis, and hemochromatosis. They affect the heart because of abnormal deposits in the heart tissue, making it stiff, impairing function.
Wow, those are some serious conditions. It's crazy how many things can affect the heart.
It is. And sometimes the cause is unusual. Have you heard of Takotsubo cardiomyopathy?
Isn't that broken heart syndrome?
Yep. It's temporary, the heart muscle weakens, usually triggered by intense stress, either emotional or physical. It shows how connected our minds and bodies are.
Wow, that's wild. It's a good reminder to look at the whole person, not just their symptoms.
Exactly. And let's not forget about peripartum cardiomyopathy. That one happens during or after pregnancy. Rare but serious.
Okay, so lots of causes, but how do we actually recognize CHF in a patient? What are we looking for in their history and physical exam?
Let's pretend I'm the patient. What questions would you ask me, Doc?
First, tell me about your shortness of breath. When does it happen? Worse, lying down, waking you up gasping. Those details can help us figure out the severity and the cause.
Okay, so shortness of breath is a biggie. What else?
Fatigue, weakness, feeling tired all the time, hard to do things you used to enjoy.
What about swelling, swollen legs and ankles, that sort of thing?
Definitely. That's called edema, fluid buildup in the tissues. So yeah, any swelling, especially in the legs.
And chest pain. Always a heart problem, or could it be something else?
Yeah, we always take chest pain seriously. If it's CHF related, it's usually from decreased blood flow to the heart. But it could be angina, from coronary artery disease, or even just heartburn.
So don't jump to conclusions.
Right. I'd also ask about your appetite, sleep, any weight changes. subtle clues.
So lots of info from the history. What about the physical exam? What signs of CHF are you looking for?
First, just your general appearance. Anxious, sweating, breathing fast, heart racing. These can all be signs your body's trying to compensate.
What about those neck veins? You'd be checking those, right?
Absolutely. Looking for jugular vein distension. When the heart's not pumping well, blood backs up, those veins stick out.
So bulging neck veins, bad sign.
We'd want to investigate.
Yeah.
I'd also listen to your heart super carefully. A classic CHF sign is the S3 gallop, that extra heart sound when the ventricles are overfilled.
Like a Kentucky gallop rhythm.
Exactly. And any murmurs, those can point to valve problems.
What about the lungs?
Essential to check those. Listening for crackles, those clicking sounds that mean fluid in the lungs.
So crackles equal a heart not pumping out fluid well.
Right. And we might even hear wheezing from narrowed airways due to the fluid.
Wow, you can learn a lot just from listening.
You really can. Then I'd check your legs and feet for edema, like we talked about, and your abdomen, any tenderness or liver enlargement, which could mean fluid buildup there.
So with the history and physical exam, you can start to get a picture of whether it might be CHF.
Yeah. But to confirm, we need more testing.
I'm curious about that. What tests would you order?
One of the first things is an electrocardiogram, or ECG. It's quick, painless, records the heart's electrical activity.
And what does that tell you about CHF?
It can show things like past heart attacks, enlarged chambers, rhythm problems, all connected to CHF.
Okay, good starting point. What else?
Next, a chest x-ray to see the size and shape of your heart and if there's fluid in your lungs.
And then the echocardiogram, or echo, that's the gold standard for heart function, right?
Exactly. Uses sound waves to create pictures so we can see how the chambers are contracting, how the valves are working, get that ejection fraction.
It's amazing that we can look inside the body like that.
It really is. And sometimes, depending on the suspected cause or if we need more details, we might do more specialized tests, like a cardiac cath or a cardiac MRI.
Okay, so diagnosis. But how is CHF classified? I remember something about the New York Heart Association classification, but the details are fuzzy.
You mean the NYHA functional classification. It's all about how much your symptoms are limiting your daily activities. Goes from class 1, no limitations, to class 4, where even moving a little bit causes symptoms.
So if I can walk upstairs without getting winded, I'm probably class I or 2.
Most likely.
Yeah.
And the NYHA classification, it helps us decide on treatment and predict how things will go, the prognosis.
So it's not just the diagnosis, it's how it's impacting the person's life.
Exactly. And then there's the ACHA stages. Those go from A to D. They focus on the structural changes in the heart, the progression of the disease.
So stage A would be someone at risk, but no symptoms or changes yet.
Right. And stage D would be advanced heart failure, needing serious intervention.
Okay, so gotta know those classifications for the MCCQE. They love putting them in those clinical cases.
They do. So know both NYHA functional classification and the ACCHA stages, so like roadmaps for CHF. Now, let's talk about actually managing this condition.
I'm all ears. There seem to be a lot of treatment options out there.
There are. But don't worry, we'll make it easy. Ready to dive into the world of CHF treatment?
Absolutely, let's go. So, treatment. Where do we start with something as complex as CHF?
Well, the good news is we have a ton of options. Lifestyle changes, meds, even advanced stuff like devices and transplants. But it all starts with lifestyle.
Makes sense. What kind of changes are we talking about?
Watching sodium intake is huge. Too much salt equals more fluid retention, which makes symptoms worse.
So, less salt. Got it. What else?
Regular exercise, super important. I know, sounds weird. Exercise with a weak heart, right?
Yeah.
But we're talking tailored programs, gradual improvement, no strain.
Like rehab for the heart.
Exactly. And of course, quitting smoking, essential. So damaging to the heart and lungs makes everything worse.
Diet, exercise, no smoking. What about other conditions? Do those matter?
Huge. Diabetes, high blood pressure, high cholesterol, all contribute to CHF. Got to manage those to protect the heart.
It's all connected. One problem can trigger another.
It's a whole body approach. Okay, so beyond lifestyle, we have a bunch of medications for CHF.
This is where I get lost. So many drugs. So many ways they work.
It can be a lot, yeah. But we'll break it down. One of the first-line meds is diuretics.
Like, furosemide, right? Or hydrochlorothiazide, the water pills.
Those are the ones that help the kidneys get rid of extra fluid, reduce that swelling, make breathing easier.
Taking away the congestive part of congestive heart failure.
Exactly. Then we have beta blockers.
Metoprolol, carvedilol. Those slow the heart rate down, right?
Yep. Slow down the heart, reduce the workload, give it a chance to work better.
Give it a break. Makes sense. What other meds are common?
ACE inhibitors like lisinopril or enalapril, and ARBs like losartan or valsartan, these guys block a hormone, angiotensin II, which makes blood vessels constrict.
So the heart doesn't have to work so hard.
Right. Improves symptoms, slows down the disease, even helps people live longer.
Wow, that's amazing. Anything new and exciting in CHF meds?
There are ARNIs. Those are angiotensin receptor neprilysin inhibitors. Pretty new, showing a lot of promise. They combine an ARB with a neprilysin inhibitor, which stops the breakdown of some good stuff in the body.
So they block the bad stuff and boost the good stuff.
Exactly. Studies show they really reduce hospitalizations and improve survival.
That's great news. Sounds like we're getting better at treating this.
We are, and sometimes, depending on the type of CHF, we might use digoxin or aldosterone antagonists.
What do those do?
Digoxin, it's an older drug, helps the heart beat stronger. Aldosterone antagonists, they reduce fluid by blocking a hormone called aldosterone.
So lots of med options. Depends on the person and their specific CHF.
It's all about personalized treatment. But what if meds aren't enough?
I've heard of devices that help the heart pump.
You're thinking of device therapy, and yeah, it can be a game changer for severe cases. One common one is the implantable cardioverter defibrillator, or ICD.
ICDs, those shock the heart back into rhythm, right?
Yep, they're always monitoring, and if there's a dangerous arrhythmia, zap.
That's some serious tech. Anything else?
There's cardiac resynchronization therapy, or CRT. Uses a pacemaker to get the heart chambers contracting together, pumping more efficiently.
Like a conductor, making sure everything's in sync.
Love it. And then for very weak hearts, there's the ventricular assist device, or VAD.
VAD, the mechanical pump, right.
That's it. It could be a bridge to transplant or a long-term solution if someone can't have a transplant.
Wow. Medical technology is wild. But the ultimate treatment, that's a heart transplant, right?
It is major surgery, but it can give people with severe CHF a whole new life.
Okay, so treatments from lifestyle to surgery. But what about complications? What can go wrong?
CHF is serious. If it's not managed well, there can be problems. One is arrhythmias, irregular heartbeats.
Those are dangerous, right?
They can be. Some make the heartbeat too fast or too slow, messes up blood flow. You can get dizzy, faint, even cardiac arrest.
So arrhythmias are big. What else?
CHO puts a strain on the kidneys, can lead to damage, even failure, and the liver too, because of fluid buildup.
So it's not just the heart, it affects everything.
Right. And CHF can be fatal. How things go really depends on how severe it is, the cause, and how well it's managed.
Early diagnosis and treatment are so important then.
Absolutely. But it's not just about meds and procedures. Patient education, self-management, those are huge.
What do you mean by that?
We need to help patients take charge of their health, teach them to recognize warning signs, how to take their meds right, and make healthy choices.
So it's a team effort.
Exactly. We're all in this together, working to improve their quality of life, help them live longer, healthier lives. Feels like managing CHF is a long game, you know? Needs commitment and teamwork, for sure.
It really is. And speaking of teamwork, can't forget about the whole healthcare team in CHF care. You got cardiologists, nurses, pharmacists, dietitians, everyone's working together. It's crucial for good outcomes.
Definitely a team effort. So bring it back to the MCCQE. What should our listeners, the ones getting ready for the exam, what should they really remember about CHF?
Well, gotta remember, CHF, it's a complex syndrome, so many causes, so many ways it shows up. Be ready for anything on the exam. Classic cases, sure, but also those weird presentations.
And it's not just about memorizing facts, right?
Yeah.
You need to apply what you know to those clinical cases. Think critically.
Exactly. The MCCQE, it's testing your clinical reasoning. Can you put the pieces together? Do you get those patient-centered care principles?
So don't just cram lists of symptoms or treatments. Think about how CHF works, how it affects different organs, how the treatments actually help.
And those staging and classification systems we talked about, those are important. NYHA, functional classification, ACAA stages, make sure you know those.
Yeah, like little cheat codes for the exam. Any final advice for our listeners as they keep studying?
Stay curious. CHF is always evolving. New research, new treatments. Stay updated on the guidelines. Read those articles. Go to conferences.
Couldn't agree more. Learning never stops.
Yeah.
Right. It's not just for the exam. It's for your future patients.
Yes.
Well, that wraps up our deep dive into CHF. Hope you found it helpful. Remember, knowledge is power for the MCCQE. Keep studying. You got this.
Good luck, everyone.